National organization is one of those. Well, I think we just started, and I started a moment early. So let me just start over again. My name is Keith Overland. I'm the Secretary General for FIX, and I think you all know what FIX is, or you wouldn't be signing on to our website, our live Facebook page. So I want to thank you for participating, whether it's the middle of the night, whether the middle of the afternoon or evening. We are a worldwide organization, so we're always looking for times that we can get folks to enjoy our educational programs and Facebook Lives and YouTube programs, just like we've got today with Dr. Cooke. Let me explain to you what we're going to do. I'm just going to introduce Dr. Cooke in a moment. He's going to be speaking on differential diagnosis for radiating upper limb pain, neuropathies, thoracic outlet syndrome, something that you could take away today and work with your patients, hopefully today, tomorrow, or when it's appropriate. We find experts like Dr. Cooke are just invaluable to the educational component of FIX, and to help keep our doctors and our members really up to speed on the cutting edge treatment protocols, research, etc. When we're engaging with our athletic patients and all patients for that matter. I also want to remind you that this is the last week. We may extend it until the end of next week, I believe, for our giveaway, prize giveaway. We have instituted a new program for scholarships where we're developing a charity foundation arm for FIX, and Erchonia was incredibly nice in donating an XLR8 handheld laser with a value of $7,400 US to anybody who donates to the charity. Has equal opportunity to participate. You could go to fix.sport and /charity, or I think it's fix.sport/contribute, I believe is what it is. Actually, not charity. It is our charity, though. And with that, I would like to introduce Dr. Jay Cooke. He is a chiropractor and neurology specialist at the Neuro-Muscular Clinic, and one of the few British chiropractors to pass the American Chiropractic Neurology Board examinations. He's just completed his master's in MSK neuroscience, and with a focus on pain and dizziness. In his clinic, he's in Surrey, working in, help me pronounce it, Woking and Surrey, UK, and he focuses on treating patients with chronic pain and chronic dizziness. So for the next 20 minutes, he'll be kind of teaching us all a couple of tidbits, and then we'll take some questions and answers. And in the meantime, I hope you're writing a little bit of a check or getting a credit card out so you can buy a couple of tickets for this wonderful laser that he will be explaining to you as well. So Dr. Cooke, thank you. Erchonia, thank you. And all members of FIX, thank you for being here and learning more so you can help your patients just a little bit better. Thank you, Dr. Cooke. You're on.
Thanks so much, Keith. Thanks for that wonderful introduction. So I was originally asked by Erchonia whether I would like to come and speak to you guys, because I've been using the laser for probably about 3 or 4 years now. But the only problem with that is you guys had Robert Silverman speaking to you about 1 or 2 weeks ago. And frankly, I'm never going to outperform him or compete with him. He's a researcher. He spends a lot of time thinking about lasers, using lasers, thinking about how to use lasers. And he's just so fluent, I'm not going to compete with him. So I decided, pick the battles, and won't challenge that one at all. So instead, what we're going to do today is, because the Erchonia lasers have FDA clearance for neck pain, back pain, and musculoskeletal pain, I thought instead we talk about differential diagnosis for upper limb pain and peripheral neuropathies. Now, the only problem with that title is it has a distinctive neurology taste to it, which will send a lot of you just running for the hills. A lot of us had a fairly intimidating and scary experience learning neurology at college or university. Lots of complex terms, hard to learn, hard to remember, with a low emphasis on clinical application. So a lot of it is diagnose and refer, refer out, don't do anything with it. My own experience, when we talk about peripheral nervous system, the upper limb, was just, here's the brachial plexus, a big scary diagram with nerves flying off in every direction, and they randomly combine and then randomly separate, and some go to the front, some go to the back, and there's branches coming off everywhere, and you need to memorize it all. And after more than 12 years in practice, how many of those nerves have I ever come across in a clinically meaningful way? I'm yet to see a medial pectoral nerve lesion, and I'd love to hear from any of you that have. It'd probably be an interesting case worth discussing. So instead, when we talk about neurology, we want to bring it back to clinical life. How does it actually present in your clinic? Are you really going to see a medial pectoral nerve lesion, or do we want to more learn about the conditions we are going to see? And especially in sports, because in sports, chiropractors in standard practice are always going to see neck pain and chronic pain referring down to the arm, but they may not see that may not see a lot of peripheral nerve entrapments or compressions. You in the sports community will absolutely see a lot of peripheral nerve entrapments. Compression injuries are basically what a lot of we're going to see. Trauma-induced or compression are the two areas that chiropractors are really going to shine. When we're looking at differential diagnosis, again, it can get very complicated. So the simple thought you always want to have in your head first is very simply, is it broken? Yes or no? So a patient presents to you and they've got whatever the symptom is, very simply, is it broken? Yes or no? i.e., can they sense it? Can they move it? If they can't sense it at all, it's broken, you refer out. And if they can't move it at all, it's broken and you refer out. You may still want to be part of the treatment team, especially if you're part of a sports team, but other people need to get eyes on that to do paperwork to say that you did your due diligence. If it's not broken, then we then want to think, is it too much or too little? So is it too much pain or too little pain? Too much pain means we might have some central pain sensitization. It's going to be hard to treat. It's going to be longer to recover. Too little pain might mean we have nerve damage and they can't feel it. And that works same with movement. Is it too much movement? Are they getting, like fasciculations and stuff like this, or too much movement? They might have increased tone, rigidity, or too little movement. They got like a flaccid arm. So is it broken, too much, too little? And then what's the level? Is it out in the periphery? Is it local to the muscle, local to the nerve? Is that the level of the spinal cord, brainstem, or higher? And then lastly, we always want to make a point of thinking through vindicate. So when you've been in practice for a long time, you start to rely more and more on pattern recognition and less on thinking through pathways. So that's great because it makes you quick and efficient and your brain is very good at becoming automatic. The danger with it is we get lazy, unfortunately, and it's subconscious, right? It's that fast thinking processes which gets us in trouble. We make assumptions and have these cognitive biases. So we always want to think through vindicate. Could it be a vascular cause? Could it be an infectious cause, neoplastic, degenerative, atriogenic? Could it be congenital or compressive? Again, for us, it's often going to be compressive. Could be autoimmune, traumatic. Again, for us, especially in the sports community, trauma could be a big one, and it could be endocrine. So even if you think straight away, I know this is easy, you still at the end of your consultation want to just have a look at that vindicate and just go through them and think, is there anything that could be a better reason or something that we need to investigate for that might explain this person's symptoms? Now, the title of the talk really is upper limb radiating pain, peripheral neuropathy. The first thing you think of course, is cervical radiculopathy. And that's why we're not going to bother talking about it. You know it, it's easy. If you're a little bit rusty, all you have to go and look at is C5, 6, and 7. It's not complicated. So I thought instead we could talk about chronic pain or central pain sensitization as a cause of radiating arm pain and whole body pain. So when we use chronic pain as a description, it's not actually it's a bit like using the term dizziness. It doesn't really tell you, have they got vertigo or have they got disequilibrium? Chronic pain just tells you, often we're using it to describe length of time. But often in literature, we're often using chronic pain to describe changes in the central nervous system, allowing you to feel pain more easily. So we want to start separating when we're talking about chronic pain. We want to talk about chronic pain as in time, coming from the old Greek god Chronos, time. And we want to begin to habit of talking about central pain sensitization, so CPS, or sometimes it's called central sensitization, CS. So CPS, we're referring to pain that's no longer coupled to the presence, intensity, or duration of the tissue injury. So if I tear my supraspinatus, that's obviously going to be painful. But if 6 months later, I'm still bitterly complaining about how painful that shoulder tear is and how it's getting worse with every day, that's probably where we got some CPS. And it doesn't really mean that that shoulder is getting, is a fresh injury. Whenever we have an acute injury, we're always going to have peripheral sensitization or primary sensitization. The injury should hurt more. So if I tear my shoulder muscle, and let's say it really is acute, and it should hurt when you touch it, and it should hurt when I move it, so that I don't do that thing. So I don't let you give it a deep massage and push me and bully me around. It's that warning system saying, chill out, give it some time to heal. In CPS, what we start to see is that upregulation of pain transmission, and at the same time, a downregulation of pain inhibition. And as a result, that peripheral area might become more and more sensitive, but we also start to see pain in the areas adjacent to that injury. So CPS can occur in the peripheral nociceptors, so that's peripheral sensitization, where that injury is, those pain nerves are going to become increasingly more pain sensitive to let you know about the pain quicker. The actual peripheral nerve coming from the injury up to the spinal cord can transmit faster. So basically, it will start to develop more myelin, so the speed of that transmission is quicker. And then we see at the dorsal horn a reduced number of pain inhibitory synapses and an increase in pain excitatory synapses. So normally, if you were to look at the dorsal horn and the spinal cord, you would see a real strong ratio of pain inhibition to pain excitation. That's why I can pinch my finger pretty strong and not experience pain. We have more pain inhibition than we have pain excitation. That's why I can walk on my feet. I've got 84 kilos of weight going through my feet. That's enough to generate pain, but we've got enough pain inhibition to say there's no tissue damage there. Don't worry about it. That's why we start to lose sensation in the feet. Sometimes people start to complain about pain in the soles of their feet because they lose that pain inhibition at the same time. So we see CPS in the literature in all kinds of things. So it's been documented in whiplash, low back pain, fibromyalgia, subacromial impingement syndrome, tension type headaches, osteoarthritis, rheumatoid arthritis, lateral epicondylitis, patellar tendinopathy, and the list goes on and on and on. So what causes it? Well, whiplash is right at the top of that list. And the reason whiplash has a higher probability of developing chronic pain or CPS than other conditions because we got that high intensity of pain. So when we have an injury, if the initial onset of pain is very intense, there's a higher likelihood that we're going to start to get physiological changes in the periphery and in the central areas. The duration of pain can develop central sensitization. So if I have torn, end of the days here, guys. I appreciate you Australians. It's 4 o'clock in the morning. Well, I can't even say it's that late. Anyway, I've got 2 kids. That's my excuse. When we got a long duration of pain and we just got that constant bombardment of pain signals going into the spinal cord, that can cause it too. So when we have that intense whiplash and we sprain those facets, we get a really brutal, severe bombardment of pain nociception hitting the spinal cord, hitting the dorsal horn of the spinal cord and saying, ouch. And that in itself can immediately, within hours, produce changes that lead on to chronic pain. So they've done studies with rats, poor little rats, they give them a whiplash. And in some rats, immediately go and anesthetize the facets, and in others leave it just 4 hours. And what they see is in rats is the ones who immediately have that analgesic, so that there's no pain bombardment, they don't develop CPS. And the ones who wait just 4 hours and then get the analgesic still go on to show signs of central pain sensitization. So the intensity of pain is really important, as is the duration. Now for us, the context is very important. So for our sporting athletes, if it's me and I tear my shoulder and now I can't play tennis for a few weeks, big deal. I can't go rock climbing for a few weeks, big deal. I can wait it out. Whereas if next week was the World Championships, I've been preparing for this for a few years, and now I get hurt, that context is very different. And again, the chance of CPS developing is higher. Basically, that descending inhibition coming from the brain down to the spinal cord is very, very important. Again, it goes back to this finger. Me pinching my finger doesn't hurt because I've got a lot of descending inhibition to say, it's just me, don't chill, I'm not hurting myself. I could take a splinter out my finger, hopefully without blubbing. But if I ask you to do it, it's going to be a very different experience, because instead of having this descending inhibition telling me I'm the one doing it, I'm trying to help me, versus you're the one with the needle and you're an evil person trying to hurt me, I'm going to struggle to inhibit that pain to the same extent. And then we have psychological factors. Now, that's related to the context, but it's not exactly the same. So again, someone who suffers from anxiety or depression is going to have a high likelihood of going on to develop CPS. So when we have that persistent bombardment of pain coming to the dorsal horn of the spinal cord, there's a bunch of stuff that happens. And to keep it simple, we get upregulation of pain sensitization, we get a decrease in pain inhibition. That happens at the level of the right dermatome. So if I hurt my C5 dermatome, the C5 nerve, the level of the spinal cord at C5 is going to develop its first changes. If that pain goes on for long enough, we start to get those CPS changes. What you'll start to see is changes will start to occur in the level below. So C5 was first affected, now C6 is affected. So the pain was up in my shoulder. The initial injury was just the supraspinatus. Then CPS starts to occur. The non-injured areas around it start to become sensitive to touch or just start to hurt. I start to say that pain started here, but now it's really spreading. C6 starts to go through changes. Now that pain starts to go down my arm into the C6 dermatome. The pain continues down to C7. You know what? Actually, now the pain was up in my shoulder. Now it's gone the whole way down my arm. We see that with whiplash a lot, right? You know, I have that whiplash. God, the first couple of days, my neck was really painful. Then it spread into my shoulder. Now it's my whole arm that hurts. You'll see cases where the pain can be so severe that as it continues to spread down through the dermatomes, the pain will start to go down to their low back. Now, interestingly, for clinicians, we can test for that objectively. So we can just ask the patient, where is the pain? And that helps us. But to understand, is it just primary sensitization or peripheral sensitization, or is there a central component to this? We want to be able to poke them and touch them and know what's going on. So we've already said peripheral sensitization will always be more sensitive to touch. In secondary central sensitization, the areas that aren't injured start to hurt in those dermatomes. So C5 is painful, but now when you start to palpate through my biceps and down into my forearm, I start to say ouch as well. You know, you start to squeeze my thumb here and I'm like, oh God, that's really sensitive. Other side, no issues whatsoever. So we call that test pain pressure thresholds, and it's incredibly easy to use. So there's lots of ways to look at pain pressure thresholds. You've got pressure and you've also got heat. Now, in the early stages of central pain sensitization, we see changes in pressure first. So basically, ouch, 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 oh no, that's fine. And then later, ow, 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 oh no, that's okay, ow, you know, as it spreads further down. In the research, they found those pain pressure thresholds from a whiplash or from a shoulder injury can be reduced all the way down to the anterior tibialis on the same side. So that spreading can go the entire way down the spinal cord so that you get increased sensitivity all the way down to your lower limb. If the pain continues to go on for long enough, we start to develop widespread pain. We start to get mirroring to the opposite side of the body. And now we have reduced pain pressure thresholds everywhere, which is basically where we start to get things like fibromyalgia, which is an absolute nightmare, because you can just say, oh, I know what the original injury was, we just need to treat that. You've now got widespread pain that has no relationship to the initial injury. You know, where do you start? And that's kind of why I was interested in one of the lasers in the first place, is I had a patient who had her pain sensitivity was so off the charts that you couldn't touch anything without her, you know, screaming out. Now, how are you meant to treat someone you can't touch? You can't do any exercise with them because any movement is, oh, no, that hurts too much. No, I can't do this. So the reason I started looking into lasers in the first place is I wanted some kind of way that with those patients, you can on a cellular level start to reduce pain. And so that's why I went with the Erchonia in the first place, is because they have those FDA clearances for reducing pain. So we can just shine a laser on the painful area over the peripheral injury where it was, and then over the spinal cord, know that it's very, very safe. We're not going to hurt them, especially with, you know, non-thermal low-level laser or photobiomodulation. We've got no, real risk of hurting them there. And you can use it for 90 seconds, or you could use it for 10 minutes. And we're going to get an effect. So when we're looking at pain pressure thresholds or hyperalgesia, you can either just get very good at using your thumb and just practice using the same amount of pressure everywhere, like you would with fibromyalgia. Or we can get something called a NeuroPen, where it has a 10-gram filament on one side, and it has a 26-gram filament on the other. So it basically means it bends. So you can only ever, put 10 grams of pressure. So we can push over there, and that's what they use in the research, is they'll use a NeuroPen or a filament, and basically see when does someone say pain, because the 10-gram filament is not strong enough to activate pain normally. So if we see you're using this 10 grams of pressure and someone's saying ouch, then we know there's hyperalgesia present. That might be primary, but if it's in a non-injured area, then you get secondary. Whereas if we switch it around and we use the 26 gram, that should always be painful. As pain gets worse and worse, then we start to see changes in heat. Now, clinically, you'd have to buy a special tool to do that for you. It heats up probes and keeps them at certain temperatures. It's just really not very usable for us, for the majority of us. But if you work with someone that has it, then great. But patients might say to you, Wim Hof is very popular. You might say, hey, I think you should try and use the Wim Hof method. The cold showers be good for, regulating autoimmune function. And they say, no, cold hurts me. I'm not getting a cold shower. It's really painful, but it's a horrible experience. There's probably some central sensitization. The same for hot, right? Go and have a, hot sauna, their friend said, it'll be good for you. Or heat pack on it, and they can't tolerate it. Well, I've realized that I've just spoken, I've got into my flow and I've talked far too much about this, but for those of you working in sports, this whiplash developing into chronic pain and then radiating to the limbs is very common. But you can see it in chronic low back pain as well. Now, I really wanted to spend some time talking about the brachial plexus and upper limb peripheral neuropathies, but I've got too much into my subject, so I apologize for that.
Well, Jake, let me say that was like, I'm listening here. I'm glad I got an opportunity to host this, because you taught me things I forgot about 20 years ago already. And so let me ask you a question, and let's see if anyone else has a question. Because one thing you said was fascinating to me, and that was that when there's an acute pain, let's say in the whiplash, in the trap, or somewhere that is acute, that in just a matter of minutes, you're saying that moves up into the C5 central horn, dorsal horn, and can start the chronic pain process. I mean, I had really bad on me. I had no idea it was that quickly. So can you just talk about that for a minute? So this acute pain in a very short time will start that process. So our job, I'm hearing you say, is let's get that analgesic process going, laser, icing, manual treatments, whatever treatments we have. So just for a minute, expand upon that. Then let's see if anyone else has a question. That was fascinating. Yeah,
so that preclinical research has obviously been done in animals, because you'd never get the ethical approval to do it in humans. So it's been done in rats. So we also have to realize that the metabolism of a rat is obviously different to us. They've got a fast metabolism. But literally in 4 hours in rats is the difference between developing CPS or not, which is rapid. So if we assume in humans it's days, it means you probably have a window of days to try and stop someone who's had that severe injury from developing CPS, taking into account the context of pain for them and psychological factors. So if you're, it's like those old wartime stories. A guy gets shot in World War II. He feels no pain. He's delighted because the context is, my wartime story is over. I'm off the front line. But yes, it is that serious. So someone has whiplash, and let's say it means for them, they can't go to work, they can't put food on the table. Yeah, you probably have days to get involved. The positive side of that story is they've also done research where they've taken someone with CPS from a whiplash injury, and they found that if they can go to get exactly the right level where the initial injury was, and they can get the analgesic into the correct set level, if they reduce the pain by 80% from that injection within hours, and literally within hours, all those secondary signs of pain disappear. So someone has hyperalgesia from their neck all the way down their right side. The pain isn't just in their neck, it's all down their right body. If they can get the analgesic to the right level, and get an 80% reduction in that neck pain, all those secondary signs just literally disappear in hours. The difficulty is when someone comes into you and they've got pain all the way from their neck all the way down their right side, how easy is it to correctly identify the exact place that was the primary cause of pain? So yeah, absolutely. I think in the past, I personally have had a preference for saying to patients, oh, if it's really acute, don't come in because there's not much I can do yet. Stay at home, rest, ice, all that kind of stuff, chill out, gentle movement. Whereas these days, I'm much more keen to say, okay, well, you had a car crash yesterday. Okay, come in. We're not going to do any adjustments, but let's use the laser. Let's start doing rehab exercises immediately to try and reduce that pain response.
Fantastic. That's really neat. So I'm not sure if I see a question or not now, but I'm going to take it one more then is from a laser perspective, just explain real quickly, like just use it in your office a protocol. So if you happen to have a laser, maybe I've got one that I probably don't use as accurately as I should. How exciting is this for you in helping, begin this process of eliminating both acute, but even preventing the chronic pain syndrome to start?
It's great. I mean, that case I mentioned earlier is why I got into it. A patient you can't touch. Anything you do makes it worse. Her pain excitation was so extreme. Anything you did made her more painful. So it was nice with her just being able to shine laser on and start to get a reduction. Now you don't overthink it. That's the easy thing about it. It's not surgery. You're not basically, if they've got CPS, go to where the peripheral pain is coming from, or was, where the initial sensitization was, and shine the laser over there. In that CPS, basically, the longer you do it, the better. So the protocols on the laser are often, 2-3 minutes. You might want to do it for 2-3 minutes on the initial injury, and then you might want to do it for maybe 10 minutes over the neck or the spinal cord, basically the peripheral horn or that the dorsal horn of the spinal cord. But you can do it. That's the nice thing. It's so safe. So I'll often have the patient shining it maybe on the injury or on the spinal cord, and then I'm doing my other work. So it's not just, I'm not a laser clinic. I don't want to just stand here all day shining a laser at someone and just, cool, that's your 5 minutes. Thanks very much, John. We'll see you next week. So I might have the patient, hold it on, and then I'm doing other chiropractic stuff, to try and enforce that treatment plan. So it's easy, really. It's cool if, like I said, Robert Silverman, he knows everything about it, which is great. But for the rest of us, basically shine it on there, and on a certain level, it's supporting what you want to get done.
That's fantastic. Well, I'm not seeing, again, I'm not an expert at the whole Facebook Live thing, but I'm not seeing any questions. I want to thank you again, and the fact what you've done is, I bought a whole bunch of tickets for our giveaway because I want to win that laser now. And I'm hoping anyone who's listening or pays attention a little bit later, does make a donation at fix.sports/contribute and helps our graduates aspire to be sports chiropractors. Really, I'm going to say just like you, and I'm not blowing it. You sound like you're just a wonderful leader and expert, and a wonderful example of what every student watching this and every doctor should work to be. So, Dr. Cooke, thank you very much. If you have any last words, that'd be great. If not, we'll hopefully hook up at some point soon and meet ourselves in person finally.
Yeah, I'd love that. No, it's been a real pleasure speaking to you. I'm British. You can't compliment a British man and expect him to take it well. So, shrug that all off. But no, it's been a pleasure. I apologize if I get too excited and I talk too fast, but I love the subject, and I think it's something we should all be studying.
The passion shows through, my friend. Thank you very, very much. And I really do hope to hook up with you as soon as this pandemic stuff really calms down. So thank you. All right. Have a great day. And thank you, everyone, for joining us. We really appreciate it. And I hope you can keep in touch with Fix. We're doing a lot of wonderful things, and we're waiting for those games to start again so we can get you all back on the field, helping our athletes around the world achieve better health. Thank you. Enjoy your day.